Well, good morning, Dr. Paul Chapman. How are you?
Good morning. How are you?
I'm gonna call you Paul. You can call me Steve. So it's like
Okay.
probably less casual, more casual. So thanks again for taking the time to join us on this Beating Melanoma project. And before we get going, I'm gonna give you a brief introduction, and so our audience know how just what a melanoma expert you are. So Dr. Chapman is a physician scientist at Memorial Sloan Kettering Cancer Center. In addition, he is a also professor at the Cornell Medical College in the Department of Medicine. He's been at Memorial Sloan Kettering Cancer Center since 1988 and has a special interest in melanoma. And I would say in the last decade or so, he's been instrumental in chaperoning some of the new treatment, such as the targeted therapy, where he led the clinical trials and finally got the first drug on the targeted therapy BRAF inhibitor approved. And also, he and his colleague was instrumental in getting the first immunotherapy, ipilimumab, or Eurovay, approved. Welcome, and thank you very much for taking the time to talk to us.
Happy to be here.
No, I mean, obviously, from where you started, when you were starting and treating melanoma patient to today, that's just day and night.
Yeah. When we started, a patient with metastatic melanoma would have a median survival of 9 to 12 months.
Yeah.
And although sometimes we saw dramatic responses to chemotherapy, those were uncommon. And so it was a very difficult clinical situation. So most of us fled to the laboratory and spent a lot of time in the lab trying to figure out if we could come up with a better treatment.
Well, now I think because all of your effort, everything else, there's a more and more medical oncologists interested in melanoma, and this is becoming a very, very hot field, and because we got treatment, basically.
We have treatment. I mean, the whole landscape has changed so much that when we started, we really had little expectations for our treatments. But now we've shifted to the point where if we treat someone and it doesn't work, we're kind of baffled and surprised because we're expecting it to work now.
That's a good shift. We're going to go through a number of different categories of treatment, right? And let's start with the targeted therapy because you're the lead investigator. And so why don't you talk to us a little bit about the BRAF mutation? How does it play a role in the advanced melanoma? And what exactly is the targeted therapy?
So the BRAF protein is a member of the MAP kinase pathway. It's part of the signaling from the outside of the cell to the nucleus, and it's one of the main pathways that cells use to signal that it's time to divide. What happens in about 40% of melanoma cells is that one of these components, the BRAF, undergoes a mutation. The most common being in the position of V600. So what that ends up doing is it allows that molecule, the BRAF, to signal downstream by itself instead of what it would normally require is that it form a dimer with another RAF molecule, and that would normally be triggered by an upstream signal from RAS. But if you have in a BRAF V600 cell, that BRAF is signaling by itself as a monomer. It doesn't require upstream signaling. So it continually sends a signal to the melanoma cell to divide. What the drugs that we now have do, these are RAF inhibitors, they actually bind to BRAF, ARAF, CRAF, they bind to wild type RAF, they bind to the BRAF V600 mutant. But the reason that they are specific is because they inhibit monomers. And in a normal cell, monomers don't signal, only in a melanoma cell. So it's wonderfully specific for a mutated BRAF V600 cell. These were the first drugs for melanoma where we actually saw dramatic responses all of a sudden. Never saw that before. So now we expect responses in between 40 to 80% of patients, depending on who you look at.
Yeah, I remember the excitement when that first came out. So just for the folks listening to this, one of the analogy I like to use is that, it's almost like you have an accelerator normally requires you sort of step on it for the car to go. And with that mutation and the monomer is almost like this accelerator just always automatically floor to the
it's floored, and it's no longer responsive to the normal feedback mechanisms that would normally tamp down this pathway.
So, I think, so why don't we go through the various treatment in terms of, let's start with various stages. So let's say for stage 4 disease, right?
Right.
Someone coming to you, let's say with a metastatic disease, and you've seen it on the imaging study. Can you walk us through, like, what is your approach in consulting that patient, and what do you talk to them about? How do you talk to them about their disease?
So the first step is, of course, to determine the extent of disease. Where is the tumor? Where is the melanoma spread to? Because it changes a little bit about how you would treat those patients. But in general, our first line of treatment is immunotherapy, one of a checkpoint inhibitor. Whether we use anti-PD-1 alone, or we use anti-PD-1 in combination with anti-CTLA-4, or now there's a new relatlimab, anti-LAG3. We can get into the weeds on that. It's a lot of detail.
I think we should. That's why I'm really excited about tap into like your expertise.
So okay, so checkpoint inhibitor is what I would talk to the patient about first, and our most active drug is an anti-PD-1 drug, either nivolumab or pembrolizumab. They're pretty equivalent. And in some patients, I prefer to treat just with those single drugs. Patients who have lung-only disease, I kind of think that there's not a lot of advantage to giving combination. Also, patients in whom you think you're worried about side effects, which we can talk about as well. But there is an increased response rate, increased a little bit better progression-free survival in patients treated with combination. The combination, of course, that we have the most experience with is with nivolumab plus ipilimumab. And I would say that combination is what I would rely on in patients with liver metastases, bone metastases, brain metastases for sure. The side effects are more frequent with the combination, of course.
Yeah.
But there is, I think, an advantage in terms of outcomes for in these situations where there's metastatic disease in these other sites of these organ sites. Recently, there's a randomized trial comparing nivolumab versus nivolumab plus relatlimab. It's an anti-LAG3. We know that the LAG3 antibody by itself was not terribly effective, but when they added to nivolumab, the progression-free survival was a little better. Whether they have not reported the response rate, I suspect that the complete responses were not that much different. And I've been personally a little hesitant because the toxicity is more with the relatlimab. So Nivo relatlimab is definitely an option. I'm still been a little hesitant about it. I'm not sure exactly where it fits right now.
The hesitancy is due to because you have a lot more experience with the Nivo plus Urave combination.
There's that plus the data for the Nivo Rela. We don't. What we're looking for really, what I'm looking for is our complete responses. Those are the patients that we can potentially cure, or either complete responses or really deep responses. Those data, the response data, hasn't really been reported yet with the Nivo-Rel. So I don't know if there's whether Nivo-Rel is more likely to cure patients.
Maybe we should step back a little bit because we use a couple of terms like progression-free survival, and you talk about complete response. Other people may see the overall survival and disease-free survival. Can you maybe just explain it to us what
Sure.
those terminology means? Yeah.
So progression-free survival is the time from starting treatment until the tumor has progressed or gotten worse using our standard radiographic criteria called RECIST. Overall survival, of course, is time from treatment until death or until last follow-up. And of course, complete response used to be the tumor's all gone. We can't find it anywhere, either by physical exam or radiographically. And that still is a definition. But with the immunotherapies, we've come to understand that we've got to broaden that a little bit because we're missing a lot of complete responders. There are patients who radiographically still have some evidence of tumor that we can see, but if we biopsy it, there's no viable tumor. So we now call those patients pathological complete responses.
Just
And
to get a new term.
yeah, that's a new term. And we also have another term where same thing, where the tumors have shrunk, but they're still detectable, say, by CAT scan. But by PET scan, they have no FDG uptake. So those are called metabolic complete responses. And we have more and more data now showing that those are durable responses. Those are real. So in immunotherapy patients, that's what we're going for. We're going for some kind of complete response, either metabolic. I have several patients now, years off treatment, who still radiographically have tumors in their lung, but they haven't changed in size, and they're metabolically cold by PET scan. And sometimes we biopsy them also, and they're non-viable. They're just sitting there. So those patients do quite well.
Well, when you say they're sitting there, are those melanoma cells or are they just like residual debris of the?
Yeah, if you biopsy them, you usually find that they're necrotic, dead melanoma cells, or you find that they're it's an inflammatory mass, and there aren't actually any cells, any melanoma cells, and you'll see melanophages or macrophages that have eaten the dead melanoma cells.
And you're following those patients just by imaging. You just want to make sure there's no increasing in size,
Right.
And then you combine it with a PET scan to make sure this is cold and not hot, basically.
Yeah. So one of the really fun but new problems we have sometimes is knowing when to stop treatment.
Yeah.
Right. So you have a patient who's on immunotherapy, who's had a dramatic response radiographically. It feels fine, but on CT scan, you can still see some small tumors. And they haven't, let's say they may not have changed for 6 months or maybe more. And at what point do you say, okay, we're going to stop? So in those situations is when we'll try to biopsy something or we'll get a PET scan.
So it's a yeah, you don't have a clear grasp of what's going on.
Well, it's also in the
I guess
old,
that's where your experience, that's all the medicine come in, right? You don't have enough data but you have your kind of a gestalt, clinical gestalt to sort of see and how the patient in front of you is reacting, basically.
yeah. So, and sometimes patients are a little hesitant to stop treatment,
Yeah.
understandably, but then you have this kind of funny discussion with them. Funny being odd, not hilarious, but just saying, well, we're gonna you weren't planning on being on this drug for the rest of your life, right? Right. So that means we're gonna stop it at some point, right? Right. So when do you want to stop? I mean, if you've had a patient whose tumors have dramatically shrunk and haven't changed, say in 6 months, and are metabolically cold, you can say to the patient, listen, there's nothing more is going to happen down the road. We're not going to come to another point where we'll say, oh, now's the time to stop, right? So it's kind of arbitrary. Also, given the fact that these immunotherapies, the drugs themselves, hang around for quite a number of months, and we think that the immune mechanisms are continually ongoing. I feel comfortable at some point just stopping.
No, those are really, really interesting. But let me get back to, we sort of took a detour, and let me get back. Still coming back talking about, I want to ask you a little bit more questions. So how do you decide if a patient is go for monotherapy or the dual therapy, right? And you mentioned one aspect about if you only lung versus liver, brain, bone, and in those second cases, you will be more aggressive. You put them on a dual therapy. What about the patient itself, like the age, the comorbidity? Does that take into consideration?
It can. The patients, some patients, if you give them a choice, some patients will opt for the lesser treatment in the hopes of having less toxicity. But it is a bigger problem in patients who are very medically unfit for
Yeah,
side effects. And it doesn't sound like it would be a big problem, but it's pretty common that patients have underlying autoimmune conditions that make giving them checkpoint inhibitors a little bit of a problem. Patients, with inflammatory history of inflammatory bowel disease, for example, inflammatory arthritis, those things get worse on checkpoint inhibitors, and so that makes it harder to treat those patients. But as a rule, all things being equal, the way I do it is my default is to give a PD-1 only, unless there's something that's moving me to give two drugs. It's usually the extent of disease.
gotcha.
Brain for sure. We know for sure brain metastases respond better to dual therapy compared to Nivo alone.
And then we touched a little bit. I mean, I think when I remember, like when those immune therapy first came out, and there were some serious side effects, right? And like perforated colon and pneumonitis and all that different things. Do we have a better grasp in managing those side effects? And do you and your colleagues have a better sense of can see who is going to get into the trouble, how you're going to intervene earlier? Like, where do we stand in this situation?
So I think where we stand now is that oncologists who use these drugs a lot have become very sophisticated and sensitive to the side effects. And so I know we are, and we will tell patients up front, here are the side effects to be on the lookout for. And I will stress to the patient the two side effects that I need them to tell me right away about. That is to say, those are colitis and pneumonitis. those are the ones we need to jump on quickly.
What are the symptoms for colitis and pneumonitis?
The colitis is just, it's watery diarrhea, right? And so I will tell patients that if you start having more stools or softer stools than is normal for you, you've got to call me. So I want to know. I don't want to get a call that you've been having 7 days of watery diarrhea 10 times a day. That's too late. I want to know early. And
How early? How early?
right away, as soon as there's a change in bowel habit, I mean, I want to know. I may not treat it, but I'd like to know at the beginning. And pneumonitis, it's cough and shortness of breath. Those are the symptoms. The other side effects that can happen, a rash, if it's not, we'll treat it, but if they don't want to, it's not an emergency usually, right? And hypothyroidism, hypopituitarism, those are usually gradual. It's not, we'll be checking for those anyway. We'll be checking for transaminitis. So those are the ones that I want to know about right away. And so we're really aggressive at treating those. I think that answers your question about the outcomes.
When you're treating the pneumonitis, colitis, do you stop the medication or do you put them on steroid or what do you do?
We generally have to put them on steroids. And there's no point in continuing the treatment at that point while they're on steroids. So we give them a high dose of steroids that we hope to be short, anywhere between 3 and 6 weeks is usually enough. So say if it's colitis, we usually start them on prednisone, a milligram per kilogram or 0.5 milligram per kilogram. And then usually to expect the diarrhea to stop in a couple of days, and then you can start a slow taper. One of the tricks is that sometimes the prednisone doesn't work, but if you bring them into the hospital and give them IV steroids, it works because they're not absorbing it.
Yeah.
And there are some patients for whom the steroids are not sufficient, and we will treat them with infliximab.
So for those out there listening, so the idea is giving steroid, you're basically tempering down the immune reaction and basically shut it down. And so the colitis is inflammation of the colon and pneumonitis inflammation of the lung. So you basically want to shut down the immune system by giving them steroid. So all right, so we touched a little bit about stage 4, right? So we got a sense, what do you do? So now let's shift back a little bit.
So we didn't talk about the targeted therapy.
Oh yeah, sorry about that. Hey, that's another question. Totally forgot. And what is the role of targeted therapy in relationship to immune therapy? Yeah,
that's a really good question, because what we always did here was give immunotherapy first, because the responses we think are more durable than the responses to targeted therapy. If you give a patient who has a BRAF V600 mutation targeted therapy, there's a very high response rate, but there's about an 80% relapse rate. So 20% of patients will have a prolonged response to treatment, but a lot of them, 80% will recur. So we always would give immunotherapy first in a patient who has a BRAF mutation. There are now data in the DreamSeq, in a study called DreamSeq, where patients were randomized to start BRAF inhibitor, or they were randomized to start immunotherapy, and then switched when they recurred. And the data were clear that we were right. That immunotherapy, it should be our first treatment for these patients.
And when you give the BRAF treatment, you always give the BRAF and the MEK together, right? That togetherness, and also still give you only the 20% prolonged durability. What is your decision-making process in terms of you giving immunotherapy first? Is it only when that doesn't work and it stopped working, that's when you start targeted therapy?
Yeah, so all things being equal, you would start with an immunotherapy, and switch to a targeted therapy if it doesn't work and if they progress. There are situations where you don't do that. one situation that comes to my mind right now is in a patient with brain metastases
Sure.
who a lot of times they're on Decadron because of edema. So in those patients, if they have a BRAF mutation, we'll start them on a BRAF inhibitor first.
You want to shrink the tumor, basically.
You want to shrink the tumor because there's no point in giving them immunotherapy when they're on Decadron, right?
Sure. So Decadron is another one of those steroid. It suppresses immune system. So once you're on Decadron, the immune therapy is not going to work. So that's why you got to get target therapy first.
So in those patients, we'll put them on a BRAF inhibitor in the hopes of we'll shrink the tumor, be able to get them off the immunotherapy, get them off the steroids, and then we can switch them to immunotherapy.
Well, that was good. That was good, like sequence and discussing about which one to give and targeted versus immune, everything else. So Carl, now let's shift back to stage 3. So what do you do at this point?
So this is just a sort of a spoiler alert. This is controversial.
Right? No, we haven't got to the controversial stuff yet. It's 2B2C. It's even more controversial.
Stage 3 is controversial. So so when you say stage 3, these are patients who have generally metastatic disease to regional lymph nodes and are potentially resectable, right?
Yeah.
So the question is, how do we do this? Now, this treatment paradigm has been changing rapidly over the last 2 or 3 years. In the olden days, that is to say, 5 years ago, the treatment would be surgery. The first treatment would be surgery. They have,
you mean you're talking about the complete lymph node?
Correct. Or you have a patient who's recurred in a lymph node area, right? We would do surgery to render them free of disease, and then discuss adjuvant treatment. You know, back in the 90s and the 2000s, the only adjuvant treatment was interferon, which some people used. So now there are data for adjuvant use of ipilimumab, adjuvant anti-PD-1, mostly pembrolizumab, and in BRAF mutated patients, adjuvant dabrafenib and trametinib.
Which is the targeted therapy. Okay, go ahead.
Target therapy. And so there's data for all of these. They're all FDA approved.
Yeah.
So this is a discussion we have with our patients who come to us after surgical resection about whether or not to have adjuvant therapy. It's a complicated discussion because of the deficiency in the data, right? It's clear that any of these adjuvant treatments will decrease the risk of relapse. How much does it decrease the risk of relapse? About 20%. So if your risk of relapse is 60%, then with treatment, we can decrease that to about 40%, as for an example. What we don't have is good data to show that we've actually improved survival.
Yeah.
Because the alternative is to treat you if you recur, right? So this is where we're getting into the weeds, but the weeds are sort of important. The original adjuvant trial was using ipilimumab, and in that trial, which showed improvement in relapse-free survival, it also showed an improvement in overall survival. So that's great, except when you start looking at the details, you find that most of the patients who were randomized to observation and who relapsed, most of those patients were not treated. Why were they not treated? Because in most of the countries where this trial was done, ipilimumab had not been approved yet. It was
wow.
So ipi was not an option for these patients, and the trial didn't have a crossover. part. So yes, that trial showed improvement in overall survival, but it didn't really ask the question we want to ask. What it asked was, is IPI better than nothing? So we already know the answer to that. It is better than nothing. What we really want to know is IPI now better than just waiting and giving it later if you need it? And that trial didn't answer that. And the only trial that's addressed that is the adjuvant pembrolizumab trial, where patients were randomized to pembro or placebo in the adjuvant setting. And if you recurred, you crossed over. So if you were in the placebo arm, you recurred, you got pembrolizumab at the time of relapse. That trial is now pretty mature with 5-year follow-up at this point. And this trial again showed treatment improved relapse-free survival by about 20%, but they have yet to report any overall survival difference.
So the idea is, if that readout of the data come out and show that there's no overall survival benefit, and the temptation is, let's not pre-treat those individuals for the adjuvant prophylactic progression-free.
Because you're exposing so many patients to toxicity, right? So if you've got a patient with a 40% chance of being cured after surgery, you're going to really put them on a year of pembrolizumab and risk them having hypothyroidism or type 1 diabetes, which is not reversible, right?
And then not to mention some of the earlier, more life-threatening complications like
so
colitis. Yeah.
Whereas if you have metastatic melanoma and you treat them and the tumors shrink and they have one of the side effects, well, that's a pretty good trade-off, right?
Yeah.
But so we have this very detailed discussion with patients about adjuvant therapy, about the risks and the benefits. Benefits being a decreased risk of relapse, but no evidence of survival benefit, versus the risk, which is to say the toxicities. And when we have these detailed discussions with them and actually going over what the risks of the toxicity are, in our experience, a little more than half of the patients opt for observation.
No, that's important. I mean, also depending on who's sitting in front of you, right? And then like the way there may be another oncologist who is really more aggressive and who felt that this needs to be pre-treated, and that discussion, the nuance, the tone will sort of guide that patient in towards the adjuvant, right?
Absolutely. And so we think that's sort of unfair. I think we really, if we're going to talk to the patients about this, we have to be truthful about what the benefits are and what the risks are. And if you go through all that and the patient says, yeah, I still want it, then we give it to them.
So I guess we only have 5 minutes left. And so since this is your feeling on stage 3, I guess for stage 2B and 2C, you are even more.
Yeah, for stage 2, we don't even talk about it.
Okay. Even though there is an indication for adjuvant, but for that, I think you're looking at the benefit risk reward. You say like,
it's approved for stage 2, but if you look at that paper, it's clear. I mean, you start doing the arithmetic, they clearly hurt more patients than they help. So what I do for stage 2 is I tell patients, listen, this is FDA approved for stage 2, but I don't recommend it. Because I know I wouldn't take it if I were a patient.
No, I mean, I think this is the most important line, right? And I think at the end of the day, patient will, like, you can give them all the statistics and all the papers and all the like number needs to treat, the side benefit, and they're just gonna look at you and say, what would you do, right? And so I mean, I think
when patients ask me, I said, well, if it were me, I wouldn't do it.
Yeah. But likewise, there will be the other docs, some other docs, they will look at the data, they'll be like, hey, I will do it, right? And I think that's it's kind of a judgment call, but you have like decades and decades of experience looking at this, and then also on top of which, I guess as the year comes along and we have more data coming out, and that we will know a lot more about, what is the right choice.
Yeah, I think when the pembrolizumab trial, if they report out their survival, then we'll know, right?
Yeah.
Survival, good. But if
Because at the end of the day, it's not progression-free survival, it's the overall survival.
survival, the whole point of adjuvant treatment is that we are more like, the assumption is we're more likely to cure you if we treat you in the adjuvant setting.
Yeah.
That's the question. So so the question is that true or not?
Yeah, I mean, those are not easy drug that you take without the side effects, right? We talked about those two life-threatening ones, but you also mentioned this chronic stuff like diabetes and hypothyroid and not to mention like arthritis and all of that stuff.
Yeah.
And it's not easy.
Not easy, yeah.
Paul, I can't thank you enough, and I really appreciate the subtlety and the transparency and honesty of your discussion, right? And I think those kind of a nuance will never gonna come out in a book, in a page. It's only will come out in this kind of live interchange, like a dialogue, and then you can sort of see, the risk and benefit. Thanks again for doing this, and I would love to interview you again, and maybe when the Pembro readout come out, and we will have a better idea.
Happy to do it, Steve. Always for you.
Thanks again.
Yeah.
Stay
Bye-bye.
well. Bye.